I am Tina Pinion with USA Senior Care Network, and before we get started with the presentation, we have a few quick announcements. This session is worth 1.5 CPE credits, and if you require them, please sign in on the iPad at the back of the room. We value your feedback, so please take a minute to complete the session surveys. Surveys will be sent to the email address that you provided at the time of registration and should be received 15 minutes prior to the end of each session. A link can also be found on the conference app. Now, I would like to introduce Dennis Dahlen, National Chair of HFMA. Mr. Dahlen is the Chair of HFMA for the 23-24 term, a member of HFMA since 1987. Mr. Dahlen also served as Chair-elect during the 22 and 23 term and as a Secretary-Treasurer of HFMA during the 2021 and 2022 term. Dennis Dahlen, CPA, MBA, serves as Chief Financial Officer of Mayo Clinic. Dennis?
Thank you for that kind introduction. It's always great to have a super introduction. By the way, as I've checked with past chairs and other speakers from National that come out to chapters and speak, 8 a.m. is like the worst time slot, right? Because generally there's something that went on the night before at these meetings. Was there something that went on last night? Any of you were out late or anything? But I'm pretty impressed actually. Most of the seats are taken, and that's terrific. Anyway, I'm thrilled to be here. Many of you have been so. Thank you for being here, but it's really me that must thank you for the invitation to be here. It's being a national chair is a humbling and an experience and an honor for me, and it's really in service to all of you. So thank you for the invitation. It's my pleasure and privilege to be here today. So I'm going to start by hopefully. I'm well into my year as chair, so hopefully you've heard about the chairman's theme. It's time, so that's not a surprise, hopefully. But I do want to unpack it a little bit and sort of give you a sense of what I was seeing, feeling about a year ago when I was putting this theme together for the year, and how it's played out over the year. But let me just start by introducing myself a little bit. You already heard that I've been a member of HFMA for like a lifetime, 39 years. I've had the privilege of serving in 3 chapters and being a member in 3 chapters. I started when I was very young in my career on the plains of North Dakota. That chapter had 140 members. And if you know North Dakota, there's only about 4 places that have hotels you can actually have meetings at. And so we traveled to rotate through those 4 cities, and we'd pull together education and training and materials that was useful to that group. Worked very well, and it was a very successful chapter. We were always was fun to go to the award ceremony every year and get those medals and those trophies. It was good. So we did a nice job for those 140 members. And then about the turn of the century, I moved to Arizona, where I ultimately became the CFO at a company called Banner Health, and sort of stepped back. Wasn't active. I wasn't going through chapter roles or anything, but I was certainly supportive of the chapter. And that chapter, of course, Arizona, another big state, several small critical access hospitals, some border issues that were going on all through my time in Arizona, as well as a couple of large metro areas with academic medicine and all of those sorts of things. So much different chapter, hundreds of members, not just 100, but hundreds of members doing what they could do in service to Arizona, but doing it in a much different way than North Dakota did. And then for the last 7 years as CFO of Mayo Clinic in Rochester, Minnesota, I've been a member of the Minnesota chapter, again, not active in the officers or the board or any of those, but certainly speaking, being participant, supporting them at social events, doing all of that, and becoming an enterprise member and flooding them with denominators, members for the chapter. And so 3 different chapters doing it 3 different ways, but yet all part of an organization we know and love called Healthcare Financial Management Association. Does everybody know how big we are these days? I literally, as I give this talk, I've had to update the number almost every single time. It's today, most recent number, it's 113,000 members strong. That's 113,000, yeah, absolutely. Yeah. and that's a credit to all of you. But the beauty of this model is, I stop and contemplate this. So you've got these local chapters. I was talking to Brad, who's a member of the Chapters 2.0 initiative. We're talking about this local versus national organization piece. I think we got it right. You know, you've got this local chapter flavor where you're addressing local issues that can't really be addressed at a national level because it's not of interest to everybody, right? But you've got this national organization that has the heft and the mouthpiece and the recognition that's 113,000 members wide and deep today, that gives us credibility and amplitude and volume. So it's a terrific model, and I couldn't be more thrilled to be your national chair. I grew up on a farm. Any other fellow farmers, recovering farmers? Yeah. Yeah. I loved growing up on a farm. It was a family farm. I knew from a very early age I was simply free labor for my parents. They loved me, don't get me wrong, but I was also free labor. I had no interest in farming. I left skid marks when I graduated from high school. But one of the things, it was my formative years, and one of the things you know or learn when you grow up on a farm, or you are in a farming vocation, is that the work that has to be done in any given day, week, month isn't really yours to decide. It depends on lots of things, mostly the weather. But what it imbues in you is a sense, and it certainly did with me, is a sense that when the conditions are right to do something, you've kind of got to do it. And that really was the impetus or the genesis of the It's Time chairman's theme for the year, because it feels to me a little bit like farming, and there's only so many sunny days, and there's only so many warm days, the growing season's only so long, that the time is right. It is time for us to take a stand, to take a step, to create some forward momentum in healthcare. And I'll unpack that a little bit as we go forward. I love Herbert Stein. I've been using this quote all year. If something can't go on forever, it'll stop. And the beauty of that statement, of course, is its simplicity, right, and its common sense nature. But the takeaway is a little bit more complex than that, and that is really, if you agree with that statement, the question really is, well, what do you do about it? If something can't go on forever, do you just let it stop? Do you let it crash headlong into a brick wall and destroy itself? Or do you try to manage it to a successful transition on a gradual slope or slope up or down or sideways? I think we all want to manage a transition, if necessary, to what we do and how we do it in as gradual a fashion as we can so that there isn't a headlong crash into a wall. It can't stop immediately because it would be too harmful to all of us, our friends, our neighbors, our colleagues. So I pay a lot of attention to health systems, health system performance. Lots of other people do as well. They're called rating agencies, bond buyers, all of those sorts of things. Now, health system margins have generally been pretty good. Now, this is a graph of the top 100 health systems in the nation. 2022 was a horrible year for them. Now, of course, as I was starting my chairman's year, that was the most recent year we had. And this is the year-over-year change in operating EBITDA, cash flow, essentially, year-over-year. You can see lots of decreases. Now, again, 2022 was a really bad year. But I've been watching it since. 2023 is it's gotten a little bit better. But the median operating margin amongst these top 100 health systems is still like 0.5%. It's not sustainable. It's not financially sustainable. They can't continue at that. I was fortunate enough to be part of a HFMA-sponsored CFO collaboration group. It's called the Large System CFO Group about a month ago. We met in Phoenix, and the group sort of, we go into a room and we literally, we close the door and we just talk. So no notes are taken. We just share what we're seeing, what we're thinking, what's working, what's not, and what we see the outlook is going forward. And one question that was asked was this: how soon will it be before you're at pre-pandemic levels of performance? And there were about 20% that said we're already there, which is good. There were about 50% that said it's going to take 3 years, okay? And then there was another, let me add that up, 30% that said never. It's never going to come back. We're never going to be able to roll back the clock on labor shortages and the wage increases we gave. We're never going to catch up on the top line. And that's kind of sobering, right? Because large health systems, these top 100, are the most evolved organizations in the healthcare ecosystem, right? They're formed. They grew to be successful in the current market, the way we finance and pay for and deliver healthcare. And if they're suffering, imagine what everybody else is doing, right? They're the most advantaged organizations and participants in the health system, in the overall health system, and we can't. And if they're not being successful and not at a sustainable level of performance, probably nobody is. Oh, yeah, so this was the combination of both of those 2 years. You can see that they're still mostly underwater if you compared it to pre-2022. And labor cost pressure is certainly the most significant input into that. This is the change between 21 and 22 and the percent of labor as a percent of revenue, not the change in labor expense. It's the percent of revenue that has changed. And you can see what far over on the right, you're getting to the 6% year-over-year range, increase range. Nobody's making 6% margins, or very few. There's a handful of people that are making 6% margins. So if you give up 6% to labor increase as a percent of revenue, you're giving up your margin and then some. And that hasn't changed at all either. This is the same thing from 23 compared to 21, mostly up. And why is that important? We're addicted to labor as an industry. We have an abysmal record of being able to deploy and employ technology to improve productivity at all. That number on the top is us. We have actually had negative productivity growth over the 15-year period that was studied here. You can see that the economy as a whole grew 25% from labor, 75% from employing technology and increasing productivity. Our numbers are 99% labor, 1% productivity and technology. We actually are worse than state and local governments, which is kind of sobering. It's a low bar, and we didn't even meet that. So this is something that's it's time to change this dynamic. I'm also a little concerned that policymakers are becoming a bit impatient with us. This is on your left, my right, the AHEAD program. Has that gotten any traction in this neighborhood? It came out from CMS last fall, September-ish. So our national staff sort of looking at this, and I know there are some large health systems considering this, but I would describe it as essentially a left turn by CMS. We spent the last decade plus talking about value-based care and shared savings models and all of those sorts of things that really put us in the position of trying to manage the cost of care, right? This it's absolutely a left turn, really almost towards the Maryland model, right? All payers, hospital global budgets, earmarks for primary care, mental health. It's much more of it's all payer, by the way. It's all payer. I don't know if there will be any takers. I don't know if it'll be voluntary. I don't know if it's good or bad. But it's something brand new, and it tells me that perhaps CMS is becoming a little impatient with us in the pace of change. On your right, my left, I'm also watching, and partly because that one at the bottom that's in light blue, we fought, I was part of the fight in Minnesota, trying to fight the formation of a healthcare affordability board. Actually, does Washington have one? No? Yeah, I don't think Alaska does. So you're safe. Yeah, you're not up there. So these are states taking matters into their own hands, really adopting some of the things that were being considered in Minnesota. Was actually they were modeling it directly after the first one on the list, Massachusetts. They wanted to replicate the Massachusetts model, which if you speak, I know it's all the way across the country, so maybe you don't speak to the folks at Mass Gen Brigham very often, but it has not been a positive for them. They are struggling to maintain their quality and their sustainability under this regime of Healthcare Affordability Board. And we were worried about the same thing at Mayo Clinic in Minnesota. So the rise of these, and there are some red states in here. Indiana, highly Republican state. They decided to have one as well. And they've imposed some fairly strict mandates on pricing and rate increases. And it's, again, states I think are getting impatient as well. Also watching losing the battle for hearts and minds. 3 years ago, we were in the midst of a crisis, COVID. Our colleagues were working in warlike situations, in EDs and ICUs, really, truly in wartime-like conditions. We're hailed as healthcare heroes, first responders, all of those sorts of things. Now we're being criticized for serving the most fortunate amongst us and not the least fortunate. We're moving facilities or services out of neighborhoods that need them into neighborhoods that are more likely to pay for them, of treating our more affluent patients better than others by preferential treatment. There's even a series of articles about large health systems redirecting provider relief funds to create our labor issue by pumping up salaries. This is the kind of press we're getting. And so is it justified? Perhaps. Is it all justified? Absolutely not. And we've got at the national office, we've got a gentleman named Brad Dennison who's, I don't know if you follow this blog, the Blame Game, Healthcare Blame Game. Just last week, or was it earlier this week? I think it was last week. Called out, are you familiar with the, was it the payment PRA? I forget what the acronym's for. They put out a report that showed hospitals 36% compliance with price transparency. Now, I don't know about anybody that works for a hospital here. We're as compliant as we can be without price transparency. I don't know anybody that's not trying to be compliant with it. I mean, there are penalties. I mean, come on. Anyway, 36% is sort of laughable. And Brad and the team dug into it and found it was pretty laughable. I mean, CMS says it's 70%, so 36%, but yet it gets, of course, a lot of press. Anyway, we're using the force or the strength of 113,000 members and a good editorial staff, great editorial staff at the national level to sort of push back against those. We've got to step into the breach and push back where the reporting's not accurate. As I've traveled across the nation for the last several months, one commonality persists. I see a few nodding heads. Medicare Advantage working great for everybody here? Yeah, no. So, and it's not for me and my day job either. We really struggle with Medicare Advantage, and there are starting to be reporting around health systems terminated contracts. And I do think, just last week I heard a terrific economic report on Medicare Advantage, the large plans. A surprising percentage of their earnings, United, Aetna, Cigna, Humana, obviously, come from Medicare Advantage. They've become addicted to the profits from Medicare Advantage. And with the change in stars, change in RAF scoring, all of that, it's attriting. And where does gravity take them for the reaction? It takes them to us, right? Because we are a cost to them. And so that's what's happening here. They're addicted to the profits. They can't forego them. Their stock price depends on it. And I'm a capitalist, by the way. That all works. I like that. But they can't turn into bad actors. And I think the HFMA piece in this is that we, collectively as an association, we collectively as an HFMA CFO group, we collectively as financial leaders in healthcare probably need to take a stand here and just call it what it is and be public about it. let's act as an industry, strengthen numbers here. Let's do something big on Medicare Advantage rather than just sort of take it. And if there's one element here, and we also know this from, I should have asked, are there any Medicare Advantage plans in attendance here? Missed that one. Well, I'm glad. So if you don't want to raise your hand, that's fine. Or if there are none, that's even better. But we also know, like many of you, I suppose, we hire people that used to work at Medicare Advantage plans. We know their business model because they tell us. It's denials. That's what creates the profit and creates our headaches. And so we've got to figure this out, right? Let's be proactive. I'm going to turn a little bit to hope now on the flip side, and that's really the it's time piece. Is there's a time of some trauma and some real strong indicators that what's working, what we're doing isn't working, and there's tons of hope as well. This came from a reported story last fall in the New York Times. You may have read it as well, but this is the Medicare spending per beneficiary per year, from its program's inception to about 2011. See, it was a couple of jogs in the line, but it's mostly a straight upward path, compound annual growth rate of about 6.7% to 2011. At that point, the Medicare actuaries suggested that by today, or by 2023, it'd be north of 22,000. So continued growth, actually a little bit increasing. But the real surprise is what actually happened. It flattened. Since 2011, it's been flat. Here's the other surprising thing. CMS has no idea why. They don't know. When asked, they don't know. When the reporter asked, they said they don't know. I was at the Thought Leadership Retreat last fall. Right after this article came out, the chief strategy officer for CMS was there, and we asked her specifically, and she said, we don't know. Well, it's important that we know. Because if it's working, we should replicate it. We should scale it. We should make sure it stays in place. Now, likely there are some contributors to this that are transitory. Could be the age-ins are healthy. Maybe we've got this baby boom bolus at the lower end of the Medicare Advantage curve that's dampening demand for medical services. And if that's the case, we need to know that as well, because in 10 years, that bubble's going to be in a different part of the demographic and medical needs curve, right? It could be all of the work that we do. What else happened in the early 20-teens? 2011, 2012, feel like an ACA kind of came in. We've all been working in this space, right? So I think we can take some credit for this. I think we all impacted this. Hope for medical science. There is a reason that last year, New York Times suggested that we're in the golden age for medicine. It's because of all the things that are going on in medical research. There's CRISPR. We all know what CRISPR is. It's the kind of the Swiss Army knife for gene splicing and gene editing. Whole host of things like sickle cell disease, congenital blindness, heart disease, HIV, can be cured with that. And those are just single cell mutation diseases. Wait till we get to multiple cell mutation diseases. It expands the field like this. mRNA vaccinology, we all know that's how we got the COVID vaccine. But it also opened doors in terms of accelerated processes and a whole host of new things that are listed here. Zika, tuberculosis, again, HIV, RSV, some cancers. New cures, we've got, we're delaying type 2 or type 1 diabetes with monoclonal antibodies. We're also seeing increased, orders of magnitude improvements in breast and rectal cancer treatments. It improves life expectancy rapidly. Cellular senescence is something that Mayo Clinic's participating in, but others are doing it as well. It's studying the way cells age and the toxins that build up. And then if we can figure out a way, and we are figuring out ways to remove those toxins, those cells don't cause us to age. And if we can stay healthy, the interesting part of the research, at least so far, is it doesn't increase lifespan. It just increases healthy lifespan. So, taken to its limit, you would be healthy as a horse until the day you expire, you fall into the grave, and then you're done. But that would be better, right? We haven't cured mortality yet. And then, of course, breakthrough diagnostics. Many of you are, I'm sure, seeing this, is that we're applying machine learning, artificial intelligence, predictive artificial intelligence to imaging, lab tests, pathology, trying to increase the signal-to-noise ratio, and we're being very successful in doing that. This is, I'll just tout one thing that I've seen in practice at Mayo Clinic, and that is we've been able to apply artificial intelligence to abdominal MRI scans. It can detect pancreatic cancer 18 months earlier than it ever could be before. That 18 months is critical, right? That's stage 1 versus stage 4. So, compelling stuff. Data science. The last speaker yesterday, Eric, covered a little bit of this, but we're an immense part of the global data pile. 30%, we're growing faster than everybody else. And it is largely a garbage heap of data. I figured it was some number of, from here to the sun or something in paper or something like that we learned yesterday. But we are starting to mine this. So Truveta, a few health systems banded together, put the clinical data sets together. They're using it primarily to help pharma identify clinical trial participants sooner or better or more easily. Inference, it's a utility. We're using it. Others are using it as well to transform decades, all of those pieces of paper, unstructured EMR data into something that can actually be used to improve diagnostics and therapies. Culmination, it's an Intermountain startup focusing on the omics dimension of data. And of course, ChatGPT, we're well aware of that. How many of you are working on something in generative AI, large language models? A few hands. One of the asks I got from my CEO late last year was actually like 2 weeks past the budget approval deadline. Says you need to put $40 million in next year's budget for generative AI. That's how much we're spending on generative AI. Talking about foundation models of, becoming, sort of the bot that can enable all kinds of things across the globe. I mean, really aspirational stuff. But there's also really easy stuff like ambient listening, surgical surveillance for skills, quality reporting, all of those sorts of things that are probably certainly lower hanging fruit. I love innovation and disruption. And I think too often, having spent most of my professional life in healthcare and in leadership at large health systems, I think too often my reflex action, and many others, is to stiff arm innovation. Is that the pie is not going to get any bigger, and so don't take my stuff. I actually think that's completely wrong. I've had a bit of an epiphany, and that is we should embrace innovators. If somebody can, these two examples on top are in primary care space. I know for a fact that none of us do primary care very well. Some of us do it better than others, but nobody's doing it. Nobody's knocking it out of the park. And even more than that, it's not a huge value creator. We could do what we focus on, do better, if somebody else would figure out primary care. So I'm all in on Go Forward, which when I put this slide together a few months back, I think they had 2 locations. Now they've got dozens. I mean, they're growing. It's a technology-enabled sort of gym membership thing. It's an ex-Googler, Adrian Ewan, that founded it. It's terrific stuff. I hope they're successful. And I hope we can partner with them at some point. One Medical, of course, was bought by a local company here, Amazon. Is that, yeah. So that's about a year or so old. And I can't, I look, and I can't find any reporting on it. It's under the tent of Amazon, and I have no idea how many subscribers they've got. Of course, it's available with Prime membership. Don't know how many offices they've got, but it's obviously going quite well. I do love Andy Jassy's comment when they purchased One Medical. His quote is this. I love it. If you fast forward 10 years from now, people are not going to believe how primary care was administered. Customers want and deserve better. And that's what One Medical has been working and innovating on for more than a decade. Together, we believe we can make the healthcare experience faster, easier, more personal, and more convenient for everyone. Anybody resistant to that? If they solve it, what would you do? I don't know. I'd partner with them. Great. If we can integrate. So I think Eric, one of the things you said yesterday was it's the EMR that that sort of dictates workflow. If we can figure out the EMR thing, that would be the key, right? Let's connect the care. But I hope they figure it out. Anyway, I'm a new disciple for innovators. I think they hold a lot of answers for us. At the same time, that whole private equity, venture capital model, the folks that are working in that space, and I speak with them fairly frequently, they would tell you that that's not, if you're looking to us for all the answers, we're not going to give you all the answers. Because we've got a fairly formulaic place. We've got 5 years to figure this out, and then we have to do something with it. So a lot of problems don't lend themselves to a 5-year solution from initiation to sale. So we're not going to, they're realistic about it. They're capitalists. They're in it to make a buck, but to solve something. But we can't look solely to them for answers. One of the things that maybe is the hardest for us to do is to listen to people asking uncomfortable questions. Dave Johnson, Foresight Health, is a fellow member on the national board. He's a recovering investment banker. Much early in my career, he helped me issue bonds to build buildings, and now he thinks that was just evil on his part, that he would ever do that, because he's become a bit of an informed critic of healthcare, how we're organized, how we spend, what we're investing in and what we're not investing in. And while I don't agree with everything Dave says, I really appreciate him and have the courage to ask the questions, and ask the questions in gatherings like this, where he's got a lot of incumbents that don't like the questions. And so I appreciate his courage. And this one that I'm featuring here is, I really don't agree with him on, is that he's asking, is the end of the traditional nonprofit healthcare governance model or organization model, is it outlived its usefulness? Should we give up the tax exemption, put the tax yield back into public programs, and let them run like businesses? Yeah, I don't know if that would work. It's certainly an interesting question, but I don't know if that would work. Anyway, Dave's a believer in that. But I think the point I'm making here is that we do have to listen to the voices that are asking difficult questions. At the CFO meeting I mentioned a few minutes ago down in Phoenix a month ago, we invited another voice in that was telling us things we didn't want to hear. It was an economist from a foundation that does research on healthcare policy. So that means he gets listened to by policymakers, congressmen and women, senators, CMS. I thought we were going to have to call the sheriff when he told this group of about 30 CFOs that Medicaid pays us more than our costs. Does that resonate? Is that what happens here in Washington and Alaska? Doesn't happen anyplace else either. And so we had a few strong words exchanged. We held a few people down in their chairs, and he explained his math. Now, he's an economist, so guess what? His math was good. He just missed one input, and the input he missed was all of those intergovernmental transfers and provider taxes that we use to create Medicare sub-plans or payment schemes. He'd forgotten those, or he didn't include them. He didn't think they were appropriate to include. Yeah, it was even stronger than he forgot. He didn't think they were appropriate to include. And we said, well, guess who's paying those? And so you've got to figure that into the whole picture. Whether we convince him or not is an open question. I don't know. But it was useful to know that that's what he was telling policymakers. Until we had that discussion, none of us knew that this influential voice, a PhD economist, was speaking with policymakers, telling them that we, as healthcare providers writ large, Medicaid is paying us more than our costs. So there's no problem. Yeah, I see a few heads shaking. And so what it illustrated for me, of course, as a sitting CFO, the fire alarm's going off. We've got to get to our representatives in Washington and elsewhere to tell them that this is a crock. But it also, as the national chair for HFMA, I'm thinking, wow, what a great opportunity for HFMA to sort of step into that breach and become a proactive voice for what's right, wrong, or indifferent. We've got to start monitoring this stuff, because the conversations we aren't in are probably as dangerous as they get, right? Because we don't know what's being said. We can't even rebut it. We don't know what's being leveled, or the charges or the assertions that are being leveled. But we at least know this one now. And now it remains to be seen whether it changes anything. But at least we know about it, and we can be in the middle of it. But the value is of having somebody in the room that was willing to challenge us. And it started there. So lots of hope, lots of trauma. Things aren't working the way we'd like them to, and HFMA exists in the middle of all of this. There's 4 graphs on this chart. The one in the top left is the familiar, and that's that line above all the others is cost. That's, I guess, where the U.S. is the one above all the rest of the developed world. Over on the right is one that I'm particularly sensitive to, and that's maternal infant mortality. Those lines that are above the rest of the developed world, that's us. If we can't do something as natural as childbirth, at least to the level that the rest of the industrial world is experiencing, that's on us. We have to figure that out. On the bottom, it's disparities in health coverage and health status. All of this is sort of just indicators that it's not working. And HFMA exists in the middle of all of that, right? And we also have to consider, Ann Jordan, our new CEO, has a triad that she uses, 3 circles. Member value. We have to be of service at HFMA to each one of us, serving us in our day jobs. What am I going to do this week, next month? Make us as effective as we possibly can. Bring tools, doing solutions so that we can do our jobs as well as we can. At the same time, another circle is mission impact. And the mission impact requires a vision over the horizon, right? Where do we need to take this industry? Where do we all want to get to someday? It's not just what we do this week, next month. It's over the horizon. And that's where we've got to do both. We have to be both and. So here's the, oops. Did I use the broom signal? Am I pressing the wrong button? No, that's not it. There we go. Here's the audience participation question. Does anybody in the room know what HFMA's mission is? Now it'll show up if I can get there we go. It's to lead the financial management of healthcare. Who gave us the mission? We did. It wasn't you or me. It was people that came before us, on whose shoulders we stand. But this is what we chose. We said we want to lead the financial management of healthcare. See, it makes sense, right? Healthcare for management. I don't know what else our mission would be, but it's a good mission. And the funny thing about the mission is that there's what's the main word in that sentence? The action verb, right? Lead. And I suspect most people in this room are leaders. And we're probably in our careers to be leaders and lead and make an impact. And lead's a funny verb because, as I've learned, from a distance, it's kind of a shiny, aspirational goal. We all want to be at the front of the line as opposed to the back. It's less dusty, and you can see ahead. It's good. But then, as you get a little closer to the word and what it takes to lead, we realize that it's a little bit tarnished. It's bloody. It's dusty. It's dirty. Because leading is hard. You're moving people's cheese. Sometimes you're changing their jobs. Sometimes you're eliminating their jobs. Sometimes you're getting rid of whole processes. And so leading's hard, but it's our mission. So we've got to do it. So nobody promised us a rose garden. We're going to lead the financial management of healthcare. No, I think I skipped a slide again. Isn't there one in between? Are those? Oh, okay. All right. So, is anybody in the room familiar with the concept of punctuated equilibrium? You heard that term before? I get to hang out with the brilliant scientists at Mayo Clinic, so this is the kind of stuff that we talk about at coffee. Punctuated equilibrium is the observed behavior in systems, both natural and man-made, that evolution doesn't happen at a static or at a stable rate. It happens with rapid periods of accelerated speciation or evolution between longer periods of stasis, nothing. And those periods of rapid speciation or evolution happen really generally as a result of an external factor or something imposed upon the system itself. And so it happens in steps. And the reason that the slide is in here is I'm wondering, and I think actually, that we may be in a period, maybe at the beginning of a period, where we could, participate in a period of punctuated equilibrium for healthcare. You think about the trauma that we're going through, it's not working, all of that, unsustainable financial margins, some really at-risk hospitals, provider groups consolidating, all of that. We've got Medicare Advantage sort of pressuring us. At the same time, we've got lots of hope for medical science, golden age of medicine, all of that. Could we be at the period where we actually increase, we go through those periods of rapid evolution? I think so. And I also think HFMA can be part of that punctuation. I think we can support it and move it forward. Chairman's themes last a whole year, but only a year. And so it's got to be, chairman's themes have to be appropriate in the longer term. And so I did want to just do a quick unpacking of where we've been over the last 5 years, including this year. This will be like a history lesson for all of you HFMA nerds, but Kevin Brennan over on the left. Imagine tomorrow. When he was chairman, he gave us kind of a soft ask of think over the horizon, not just today, but think over the horizon on a better future. What could you imagine if not constrained by the way things are today? Mike Allen, 3 presidents ago, or 3 national chairs ago. If you know Mike, he's a little bit more pointed than perhaps Kevin is. And so he figuratively stuck his finger in our chest, pounded it in there and says, I dare you to move, DY2M. Tammy Jackson, 2 chairs ago, did a fabulous job of appealing to our better angels, asking us to participate and make a bolder, brighter, better future for everyone, not just some. And then, of course, the local boy did well, Aaron Crane last year, with Ignite the Spark, hailing his upbringing in the lumber industry in the north, in this part of the country, to ignite the spark to pursue something that's better than what we're doing today. So it is time. It's time to reflect. It's time to celebrate. We're 75 plus years old, 113,000 members. We're doing something right. And to that, I don't know if Ann Jordan has been out to this chapter or not, but if you get a chance to, some of the leadership certainly has met her. I am absolutely blessed to be in my chairman year with Ann as her first year as CEO, because she's a breath of fresh air, and that is no slight on Joe Pfeiffer. I loved working with Joe. He did a terrific job. But every person that follows us will have a new set of eyes, and we'll see things a little bit differently and bring new skills. And so Ann's doing that. She's an association person, not a healthcare finance person. She knows how to run associations, and she knows how to create member value and mission impact. That's what she's doing. She is making the rounds with the other healthcare association leaders, and what she's finding is kind of enlightening, and that is that they different versions of the statement. Wow, we've been waiting. We've been waiting for HFMA to step into the shoes that we think you should wear. Be with us. Be that trusted advisor. Share what you think. Don't be quiet, don't be in the background, but be a little bit more out front. We're not going to be HA, we're not going to be lobbyists, we're not going to take position papers, but we can be we are probably as intimately familiar with the guts and the details of how healthcare is delivered in this country than any other organization. And so we've got a role to play. And it's been rewarding, and the enthusiastic response Anne's got is she's made the rounds to, HFMA should do this, HFMA should do that. It's been very, very rewarding, and it's opened some doors that we will be stepping into at a national level to make that the voice of 113,000 of us heard more frequently and more effectively. So lots to do on that front. The last bullet there is to act, though, and that's really in part of what I just described, but in all ways we need to act, we need to move forward. So the national organization, just unpacking this a bit, we're leaning into collaborations and partnerships. We already collaborate and partner with many organizations, but we're doubling down on that. Thought leadership and advocacy, more to come from that, even though we do it already. More in benchmarking and metrics. We're engaging some partners. I'll unpack that a little bit. Research, tools and researches, and of course education and training. That's our foundation, is education and training. I launched 2 task forces when I became chair. One of them was around governance. The last governance task force that we had was around 2011 or so. So about every 12 or 15 years, we should probably look at governance. One of the reasons I formed the task force, we're about to deliver our some of the findings and some of the senses of that task force here in the next month to the full board, was that around the 3 circles of member value, mission impact, and operating efficiency, there might be some different ways to govern it more effectively. And so we're looking at that. We're looking at committee structure. We're looking at all of that, efficiency and all of those sorts of things. But don't look for massive changes on the governance transformation front. But anytime you get a new CEO, it's always good to look at governance. So we did that. The other task force we formed was the Healthy Futures Task Force. And does anybody here remember the term or familiar with the term cost effectiveness of health? Yeah, I see a few nodding heads. We branded that probably 2 or 3 years ago as sort of our infinite game thing that HFMA was going to push. This is kind of a rebranding of that. Cost effectiveness of health didn't roll off the tongue, and so there's a little bit of a renaming thing. And it also felt a little bit too heavy finance for us to invite in some non-finance professionals. So the Healthy Futures work has been lifted off. Anne has thrown herself into this. She's spending an immense amount of time. This is another one of those places where it's been quite rewarding and quite enlightening to know that HFMA, where have we been? Well, we're here now, and so people are joining us in droves. We've got probably 24 people, not necessarily healthcare finance, actually probably mostly not healthcare finance, policymakers, physicians, practitioners, pundits, whatever, really joining us in this. People that have been watching the industry and have some ideas about what we should be doing to move this forward. And you can see, the sum total of all of the stuff on this slide really illustrates that, not that they would pick the same theme, but it's time. Time has come to do something on this front. You can see with the employers, the technology impacts, all of those sorts of things, it's time. Data and insights, we've got several things that are going on. These are internal value tools that we're building. These are first-party tools, the MAP app, salary and compensation data, consumerism maturity model. I find them more, and these are sort of things that have been there for a while. The new third-party tools are really, truly excellent. Some of these are good enough that I just sort of cut and paste and show them to my board, because the most often question I am asked that I don't have a ready answer to is, what's the rest of the industry look like? What's everybody else doing? How do we compare? This stuff is ready-made for that, to answer that question. So all again, as members, you have access to all of this. There's a case study of another place where HFMA has been active as an advocate. Has anybody heard of the Smart Check? Smart Check-in? Yeah? Okay. So here's the question. How this is an app or a utility that's intended to replace insurance cards, right? I find this amazing, so I'll just ask the question. How many insurance card formats do you think there are in the United States? I'll take any guess. 100. 1,000. So the group that's working on this, as you might know, is their model says it's 2,000. So 2,000 formats. What could go wrong, right? And so when we first heard about this, this came to me. I quickly passed it on to HFMA, the national office, and they dove right in. Ended up sending it over to our RevCycle leadership group. About, does this make sense? Is it something we'd want to support? They enthusiastically said yes. They'd already done all the standard setting. They know actually how to do this. What's the data stream? What are the fields required to actually lift this off? Where they're at right now is they're trying to figure out what's the model, who owns it. Is it a payer-owned thing? Is it an NGO that owns it? Is it a provider-owned thing? Is it state? What is it? We don't know what it is. So they're trying to form. I think at last pass, I think what they're trying to work on now is a public benefit corporation that would own this, and then sort of create a funds flow of service and whatever else to create this utility. It's not going to change the world, but it's certainly a step in the right direction, right? Right? We had a discussion yesterday about customer service and patient-facing or patient financial billing. This would help, right? Thought leadership retreat. Every year we sponsor a thought leadership retreat. It's by invitation only. It's mostly not HFMA members. It's mostly, this year we had a lot of physicians and a lot of nurse leaders and it's on the right, the key, it was restoring trust. That seems to be a theme at large gatherings this season. That was restoring trust was the headline for the World Economic Forum as well. So it's not just healthcare, it's not just the US, it's the world. We're trying to restore trust. And so and these reports are available again to you, Restoring Trust, 10 Keys to Restoring Trust in Healthcare. I hope somebody from this room is going to Las Vegas in June. Yeah, I see a few hands. Mike, I know I'll see you there. I always see you at the ANI, or annual conference, sorry. We have it as part of our contract. We're going to turn the heat down below 100 at Las Vegas, so it won't be as warm as normal or as usually is. But I certainly hope I see most of you or some of you at Las Vegas. It'll be a terrific time. And my call to all of you on the It's Time theme is that I ask you to be on the lookout for innovations or results that are working, because they manifest themselves primarily at a local level, right? Very few things start at a national scale and are recognized. They start at a local level. They start small. We have to grow them. And that's right in the wheelhouse for what HFMA can do. So if you see something that's working, say something, lift it up. And I've actually had conversations here over the last couple of days that lead me, that you're already doing that. So thank you. Thank you for doing that. So join those conversations, get involved. I think you're already doing that. And if you have thoughts on something that the national organization could do or should be doing that we're not, fire off an email to me or Ann or Rick Gundling or anybody at the national headquarters, because we live in constant fear that we're not doing the right things to serve all of you and serve the industry. And we also are hungry for new ideas. So the door is wide open. Nobody will ever lament getting an email with a suggestion from somebody. So I want to leave you just with, if I haven't convinced you that it's time, maybe somebody who's more decorated than I am will be able to. Is anybody familiar or ever heard of Admiral Bill McRaven? Yeah. He does speak with some frequency, so I would be surprised if some of you have heard him speak. I've heard him speak a couple of times and met him twice. Terrific individual. He was a commander of U.S. Special Ops Command. He planned the bin Laden raid, among many others, of course. He was a Navy SEAL. The last 3 years of his active duty career, he was the Bullfrog. I didn't know that this nickname existed, but the Bullfrog is a nickname given to the longest serving Navy SEAL in active duty service. And so he was the Bullfrog for the last 3 years of his career. He retired in 2014. He became the chancellor at the University of Texas in Austin. He's probably most famous for his commencement address given there that has been subtitled "Make Your Bed," in which he urges the new graduates to, if they do nothing else in their adult lives, get up and make your bed every morning. At least you'll have accomplished something. It'll give you a sense of doing something. So it's pretty common sense, advice. It just so happened he came up with his third book as I was starting my chairman year. It's called The Wisdom of the Bullfrog, and in it he labels, or he gives about 20 leadership lessons, things like when in command, command. The only easy day was yesterday. A shepherd should smell like his sheep. Hope is not a strategy. Things that you might expect an admiral to say. But the chapter that was most compelling to me was a chapter he called "Run to the Sound of the Guns." And in it he describes, now in military parlance, the sound of the guns is what? It's where trouble is, right? It's where something is happening that we don't want to happen or that has to be addressed. And so in the chapter, and I'm paraphrasing obviously to make it shorter, but he suggests that leadership can't be about not running to the sound of the guns, because you have three choices in any sound of the guns incident. You can either run to it, you can run away from it, you can stay in place. Done serially and repeatedly, doing anything but running to the sound of the guns makes you a truly ineffective leader and probably will lead to failure. So the only reason we're in leadership is to lead. And we're actually almost purpose-built to run to the sound of the guns. We're in leadership to solve problems. We're in leadership to take care of things so that they don't go wrong, right? And so in it, he makes a very good case for if it's not working or there's a sound of the guns, you should all run to it. And I think that's pretty good advice. It certainly dovetails with my theme for the year, it's time. And so, again, if Dennis Dahlen hasn't convinced you that it's time and we need to lean into this moment and be the punctuated, or help with the punctuated equilibrium of the healthcare system, maybe Bill McRaven's "Run to the Sound of the Guns" message will push you over the line. So with that, I'm going to close my comments. And again, I want to thank you for your time this morning, your attention. For an 8 o'clock crowd, this is maybe the best I've had all year, so congratulations. Is it because 8 o'clock on the West Coast is just later than 8 o'clock on the East Coast? I don't know. Anyway, it's terrific to be here. I'm happy to answer questions or take comments, or we don't have to, and we can move on with the program. It's completely up to you. Do I have one? I'll even take criticisms.
No criticism here. We are all part of this. I'm here in US for the last 25 years. So it is very interesting the way I see healthcare. You are in this ecosystem for so long. Labor is 99%, which is a part of this huge ecosystem. You have given a very good example when you started your keynote, that you guys were locked yourself into the room and talked about after pandemic how the recovery should happen.
Right.
Did you guys also talk about the scary part of how to do the disruption to take care of this 99% of the labor cost that we are getting impacted for all of us?
Yeah, it's a great question. So we do talk about it a lot. And there are this is another one where nothing happens at scale immediately. Everything happens at low scale and you scale it up. And so there are pockets of little tools and tricks that people are using that actually do create productivity and do employ technology to reduce labor cost and labor reliance. But no home runs. I mean, they're barely singles, really. I mean, I was at a hospital about a month ago, and they were demonstrating a device that was it was an adhesive about the size of it's inappropriate, but a skull, like a can of Skull. About that, you stick it on a patient's chest. It's a disposable, so it's it only uses on one patient. It's a constant stream of the vitals, so it relieves nurses from having to take vitals. In our hospitals, we do it 6 times a day, every 4 hours. So it's about 10 minutes. So it's about an hour, save time a day. And here's the problem. Here's the economic problem: is it's a $100 device, right? Now, we don't know. Will steadily streaming vitals rather than just once every 4 hours, is that going to help patient care? It might. We don't know. Nobody's done it before. So that's one element. But the other is, gosh, I can't really add $100 to the cost of a discharge or every patient without sort of figuring out how to adjust the labor. And what's going to be one of the hardest things to move in healthcare? Nurse staffing ratios, right? Really hard, really hard. So that was where the discussion went really quickly on, gosh, how do you scale this, right? Another example is, are you employing ambient listening in your clinical settings? It's Alexa off to the side listening to everything, and so the doctor, physicians, or the practitioner is interacting with the patient. It's all being recorded. There's some truly good stuff there. Here's the problem, at least the one, as I've experienced it, the early pilots are, the cost of that technology far outweighs. It's multiples of what I'll save in time. And the only way I can actually make it pay is I've got to schedule another slot, or I've got to, there's got to be more patient work involved. And this is priceless. We had that discussion with the vendor that brought us the ambient listening device, and the answer was, again, priceless. Well, yeah, it won't work at a small scale, but you've got to scale it up, and the economics change markedly. And I'm thinking, that's crazy, right? Yeah, that doesn't work. That never works. But if maybe it works for you as a salesman. So, it's a great question. I wish I had a better answer, but there's an absolute search for answers on the productivity front. I think Gen AI is going to be a big part of that. I think we're already, all of you, I'm sure, you're taking labor out of lots of the transactional processes that we as finance leaders govern and lead. We're doing a lot of that. If we can do it in the clinical space, that's truly magic.
Just a follow-up question on
Sure.
that. Do you really think that being the capitalist for this particular vertical is creating one of the big problem compared to any other countries? I come from different countries, so I compare. I have different data points. Of course, there are different problems where I come from, and every country has their own problems. No country is a perfect country.
Right.
But is the capitalism is the true problem for this particular vertical to really address something about it?
Yeah, that's a great question. Slightly provocative, but yeah, I like the question. Possibly. I don't think it's an absolute answer, yes or no, but possibly. And we know organizations probably in here and across the nation that put profits third, fourth on the list of priorities, right? Patients, community is probably higher. There are others that profits are number one, and so I think it's a mixed answer. But if I'm allowed to paraphrase Dave Johnson, who asked that uncomfortable question as the nonprofit model outlived its usefulness, that's exactly what the question he's asking, is that he sees questionable behavior on the part of nonprofit actors, and that may not, and certainly capitalist actors, or for-profit actors as well, that would lead you to believe that maybe that's not the right model. So you're asking a great question. The other point of perspective I'll give you is that one of the roles that the national chair gets to do is we get to go over to a meeting of our brethren over in the NHS over in Britain. And I was on a panel, but I was over there, and they somewhat derisively described U.S. healthcare as, you're not a system, you're a bunch of sectors, you're a sector of the economy, you're not a system, we have a system. I said, yeah, you got a system that it's going to take, and I found this amazing. There was the CFO of the NHS, I forget what his title was, but he was essentially the CFO of the NHS, was speaking, and one of the questions from the audience was, you've got these initiatives where we've got to hit these marks to get our funding and all of that, and one of the marks, I think it was for orthopedics, and this customer service standard is less than a 57-week wait from request to being seen. And I'm thinking, well, if that's what a system gives you, more power to you. That's great. I'd rather have a sector that gets me in something shorter than 57 weeks. So yeah, so it's no perfect. Thank you for the question.
You said that HFMA is not going to become a lobbyist group. The lobbyist groups are winning. So I guess my question is maybe we have to. The other side of that is maybe we find some common ground. The insurance companies, your representation of the card of 2,000 variations is just one example of what we have to deal with. And maybe we find some common ground with the insurance companies, and that common ground is not to control their profitabilities and not to control other things that are most important to them and their return. But maybe it is to find common languages across all insurance companies, like our debit and credit cards, like our ATMs, like that we can touch something and pay for it, and we don't have 45,000 variables to deal with. Maybe that's something that HFMA can go after. I know there was discussion a few years ago with the insurance companies, and almost nothing came out of it. Yeah. But we are at where you've got the graph of the flat, and then the rise, and then the flat and the rise. Well, in those flats, there's going to have to be some major breaks, and we're in those breaks right now.
Yep.
And some of us, in many circumstances, are going to lose. That's the nature of the economy that's going to happen. But if we can find those things that can stabilize and make it the ability that we can find some achievement, find some productivity, instead of constantly reacting to their demands that reduce our productivity, we may have something.
Well said. Yeah, absolutely. So on the lobbying piece, and we may be completely wrong on this, but we have a culture of not being a lobbyist. We want to be the truth teller, the fact-based, the data-driven resource, the expert in the room. And honestly, as Ann's gone around talking to, Healthy Futures Task Force has the recently retired CEO of AHIP on it. He's interested in helping us on this. AHA, we all, probably a lot of us are AHA members. Being an advocate, a proponent for anything that helps hospitals limits your effectiveness, honestly, because nobody takes your what you say at face value. And so there always is a hidden, the belief there's a hidden agenda that's just to benefit hospitals. All of those associations are telling us is that they kind of agree with the sense that we don't need to be a lobbyist. We don't need to lobby, but we can be really an effective part of a coalition in which they can lobby, and we can provide, sort of air cover and support for positions that is, unsullied by hidden agendas and those things. That, again, we may be wrong, but that's kind of where we're going.
What we're doing hasn't worked.
Very true.
So we need to look at ourselves and figure out what we can. We need to look at ourselves and figure out what we can do that's going to work and make that change.
Right. Yeah. Couldn't agree more. Uh-oh.
You talked about technology earlier, and what I'm starting to gather, technology is coming in, but it's focusing on clinical and mental health. And then you have companies now like Best Buy Health is getting into the mix, and they're working with UMass on home health because they say studies show that when a patient goes home to be cared, their health improves. And it seems like the direction is going to more a clinical home health environment.
Sure.
So it doesn't, with the hospitals, but at the same time, the finance side is not catching up to it. So how do you get the finance people to get into thinking forward thinking instead of archaic thinking?
Yeah, it's a great question. Again, no silver bullet here, but to your point, I think one of the trends that we're not paying enough attention to is the advent or the collective weight of technology available to us, both remote presence and remote diagnostics and remote monitoring, to create, the ability to do what used to be done in the hospital at home. And I was quoted in an article a while back. Mayo Clinic is an active participant in the hospital at home movement. We've got, I think, an average daily census of 50 or more of patients that are relatively acute, but they're being seen at home. Patients love it. We're about parity cost-wise, so it's not as cost savings yet, and that's part of the problem. We've got to get to where it's less expensive. But here's the challenge for us, and as incumbent market participants, I don't think we're watching this closely enough, is that if you looked at all of the transactional volume and activity going on in healthcare between venture capital, private equity, lots going on in ambulatory care, primary care, and that whole side, some in diagnostics and testing and all of that stuff, genetics, genomics, all of that. You go to the hospital vertical, nobody's getting into the hospital business. And yet, so that's the only, nobody likes the monopoly word, but it's kind of a monopoly, right? And nobody wants to get into that space. So we've got that. The point we cure that or fix that or create an alternative with home-based acute care, it's not, we don't have that monopoly in it. So I don't know if that's one of the points you were getting at, but if we as healthcare finance professionals are sitting and thinking that, this inpatient care thing that's been driving a lot of value is going to continue to drive a lot of value, I think it's probably a mistake. And to your point, I think we've got to think much more broadly, maybe with a capitalist mindset, but we've got to think more broadly about what investment's creating value and what's taking away, because it's probably not going to be just in reinvesting in inpatient care. And again, I don't know if I missed the point, but I think you're making a terrific one.
Yeah, that's because one of the things that mentioned as well is if they go into the home health setting, is how do they train the caretakers to manage the technology, and that's another struggle as well.
Right. I know I'm over time, but can I ask? I'd love to get some audience. So one of the other things that those 30 CFOs were talking about in terms of solutions was, and it's along the lines, is that we as healthcare providers are being called on to provide, to create solutions for things that we're really not trained to do or equipped to do. Food deserts, food, nutrition, exercise. I mean, we're formed and sourced to make sick people well. That's kind of what we do, right? Or treat people. Are we really going to be the individuals that would be best qualified to figure out food deserts and nutrition? How about the food companies? How about public safety? How are we supposed to do transportation? Is that our issue? And so again, no solutions. But the question was, I think where we landed was, doesn't have to be us, shouldn't be us in many cases. But if nobody else is stepping up, it kind of has to be us. Somebody's got to convene, and if nobody else is stepping up, we have to. I don't know if you'd agree with that or not. But around the mental health piece, I mean, there's certainly an environmental piece of that. There's a food deserts part of that, transportation's part of that. We've got to figure that out. But we're organized to be provide the best medical care when people are ill, and I'm not sure we're organized to be Uber. So anyway, I don't know if that's helpful or not. I know I'm over time. I'm sure you got a much better speaker than me. So thank you.
Well, we appreciate
Thanks,
your
Tina.
time.